Hello, good morning. I am today talking about progesterone and sleep. I am live on a few different places. I'm live on TikTok, I'm live on Instagram. I also have a StreamYard presentation going that I'm going to chat a little bit. I'm going to use to kind of guide my chat today. If you have any questions, let me know. But basically, I just want to put the right layout here. Okay. Basically, if you want to rewatch this or watch the recording, it will be on YouTube. It will also be in my private Facebook group. So if you want to join that, feel free. But otherwise, feel free to listen in. Again, if you can't make it, I posted a link on my Instagram where you can actually register to get the replay. So it'll go right to your email. So let's get into it. We're going to talk about progesterone and sleep and how it impacts your sleep just in general. So like I said, any questions, feel free to post on here. But the first thing we need to understand is what progesterone normally does in your hormone cycles. So for someone who's cycling, about 7 to 10 days after ovulation, progesterone will rise. I keep getting a notification on TikTok. Hopefully my phone keeps working. About 7 to 10 days after ovulation, your progesterone will rise. The point of progesterone is really your progest hormone. So this is preparing your body for pregnancy. And then if no pregnancy occurs, you will actually have your progesterone levels decline and your period will start. That's really the basics of progesterone. And so if we look at, a lot of people will say to me, oh, okay, great, because I'm on the progesterone only IUD or the progesterone only birth control. So I'm, in the clear, I got lots of progesterone. The difference is there's a big difference between progesterone and progestins. So progesterone is what your body makes, your endogenous hormone, that natural hormone that your body cycles throughout the month. Progestins will be found in your birth control. So if you are on a progesterone only birth control, such as an IUD, you're going to have progestins. They don't have the same physiological impacts as one another. So progesterone, again, cycles like I just described it. It's made by the corpus luteum. Progestins are synthetic, and oftentimes progestins are actually made from androgens. And so what does that mean? It means that a lot of times your progesterone only birth control is actually sourced from a testosterone-like source. And what does that mean? It means that you can have actually more androgenic side effects. So some people will have more acne, or maybe they have more mood issues, and that's because they have the more androgenic progestin. The other thing is that progestins are more similar to testosterone. And this is why the IUD is more likely to cause things like weight gain and hair loss. Progesterone, the one our body makes, is actually good for mood and sleep, but progestins can cause anxiety and depression, which can worsen sleep. So if we're just talking about progestin and progesterone and sleep, then that's really the connection that we need to understand here. So when we look at progesterone, it's actually known as Mother Nature's Valium because it actually provides calmness and relaxation. But we're actually going to understand a little bit more that it's kind of like a Goldilocks hormone, if you will, because there are certain levels that can be too much and actually disrupt sleep. And obviously not enough is not good as well. We want to hit like a sweet spot, right? When we take progesterone, we can have it orally, we can have it through a suppository, we can have it through a cream applied on your skin. There are a number of routes we can take in terms of like using it as a medication. But it's also classified as a neurosteroid. So it stimulates normal brain processes, eases anxiety, promotes memory. And when I'm giving progesterone to patients for the purposes of sleep, I will often recommend that they take it before bed because it has that like relaxation, almost like a sedative effect that will help with people having a better sleep. So when we look at sleep and hormones, we know that women actually have more disturbed sleep than men. And we know that there's sleep problems that commonly can happen with premenstrual dysphoric disorder or PMS. And so we know that there is a hormonal component, frequent nighttime awakenings, non-restorative sleep, people still being tired when they get up. So we know that progesterone plays a role, but we know that it's really, really multifactorial. It's not as simple as like, have sleep issues, take progesterone, everything is better. It's really not the case. It's important to understand that there are a lot of different pieces to this puzzle. So, when we look at sleep in your menstrual cycle, what's really interesting is that studies have found that changes in sleep architecture across the phases of the menstrual cycle, with most sleep disturbances occurring in the luteal phase. So, if we're breaking up the menstrual cycle and we say, okay, the beginning of the menstrual cycle is the follicular phase, then we have ovulation, then we have the luteal phase. We know progesterone increases 7 to 10 days after ovulation. Um, do you have advice for hormonal ocular migraines? Today, I'm just talking about progesterone and sleep, but I can definitely have a session on on migraines, but that's a whole other topic. So we know that most sleep disturbances occur in the luteal phase. And in the luteal phase, some women can experience increased sleep onset and awakenings and lower sleep efficiency and quality compared to the follicular phase. So then you're like, wait, progesterone rises in the luteal phase. So why would we have more sleep issues? This is why I say that progesterone's like that Goldilocks hormone, right? We have to make sure that we don't have too much and we don't have too little in order for it to properly function, in order for our sleep architecture to not be impacted. So, women in the luteal phase can actually be impacted. Now, I'm going to talk a little bit about, some reasons for that near the end, but really understanding that progesterone, we have to have enough, but we can't have too much. And so it's a big balance. But we do know that sleep issues, typically, I'm seeing it before patients get their period because that's when progesterone is at its lowest. But we can also see it when progesterone is exaggerated as well. And when we look at the menstrual cycle, we do have a number of theories as to why sleep is impacted from a hormonal perspective. But we know that your core temperature actually increases in the second half of the cycle, partly due to progesterone. And so when we have that increase, that can also impact our ability to be able to sleep. And then on the flip side, when we start to look at this in perimenopause, near, as your cycles are changing, as things are getting, more imbalanced overall, we actually see perimenopause and postmenopause, the decline in estrogen and progesterone during this time can contribute to sleep disturbances in women. And research has shown that when we treat with estrogen and or progesterone, this can actually improve sleep quality in this patient population. So it's important to understand if you're struggling with sleep, it's important to understand where your hormones at and is progesterone potentially able to play a role in alleviating those concerns. When we look at progesterone and menopause, one study actually showed that oral progesterone restored normal sleep when sleep was disturbed. In this study, we looked at 300 milligrams of oral progesterone. But the interesting thing was there was no effect on undisturbed sleep, meaning if somebody was in menopause or perimenopause and had sleep issues, and they took oral progesterone, it was able to help. This was in menopause, 300 milligrams orally. But if they didn't have disturbed sleep issues, there was actually no effect. And so this is where I see progesterone as more of a physiological regulator rather than a hypnotic, so to speak. So when we're looking at sleep aids, oftentimes we are looking at things as like a hypnotic, or like a sedative, which is just going to put us to sleep, for lack of a better term. And so when we look at progesterone often has more of a like balancing effect. So in people who needed it and had disturbed sleep, the progesterone was able to support that. And for people who didn't, it actually didn't have an effect. And so that's kind of the interesting balance we see. We see it as more of a regulator. And so if we look at this and we kind of, extend this a little bit further into hormones and sleep, we know that periods with high progesterone levels, so periods of time where your progesterone's high, so the luteal phase of the menstrual cycle, the third trimester of pregnancy, the menopausal transition, these are all associated with increased prevalence of self-reported sleep disturbances. So this means that the higher your progesterone is, you're actually more likely to have sleep disturbances as well. And a lot of times we see this when things are just fluctuating all over the place. In perimenopause, we see your hormones fluctuating all over the place. And so this is one of the contributing factors to there being an issue with sleep in that time period of life. Also, we see an increased diagnosis of sleep disorders and restless leg syndrome in these periods of time as well. And then if we look at that from an estrogen perspective, we know that changes in estradiol levels are also associated with sleep disturbances as well. Again, we see elevated estradiol. So this is also estrogen. In the third trimester, people who are on hormone therapy, people who are taking oral contraceptives, although these are synthetic estrogens, it changes your REM amount. So your REM sleep, as well as your sleep latency. And then we have periods of diminishing estrogen levels, such as during menopause, are characterized with a greater risk for insomnia and lower satisfaction with sleep. So we know changing progesterone as well as changing estrogen can both negatively impact our sleep, regardless of kind of what end of the spectrum we're at. And really, when it comes to your hormones and sleep, it's a lot just about balance. And we know that when we look at progesterone specifically, it works more as a physiologic regulator, like I had mentioned, rather than like a hypnotic or something to make you pass out and fall asleep. It's going to work more of in a balancing nature. And then we know that when someone has irregular periods and doesn't ovulate, they're more likely to have sleep troubles. And so this is where we kind of get to this sweet spot conversation. We know that in menstruating women, shorter sleep was associated with lower estradiol and luteal phase progesterone levels and increased anovulation risk, meaning they had sleep issues that was actually associated with lower estrogen, lower progesterone, and an increased risk of not ovulating. Well, we have to ovulate in order to make progesterone. And so that makes sense that, the anovulation was correlated. But what are we saying here? We're saying that sleep issues were greater in someone who had low hormone levels overall. And so when we look at these low hormone levels as a factor in sleep, typically we can use these hormones to try and facilitate sleep. But progesterone typically acts more on the sleep structure in terms of creating an environment that you have a better opportunity to sleep. And sleep can actually impact hormones on its own. So if we look at sleep in people who work like night shifts and shift workers in general, we know that night shift workers actually have an increased risk for things like miscarriage, hormone or period disruption. We know that flight attendants have an increased risk as well. And so it's interesting when we look at so specifically with flight attendants, the research has looked at an increased risk of miscarriage when work times coincide with their usual sleep period. And so there's something big to say about their circadian rhythm and the way your hormones interact with that circadian rhythm in creating that sleep that is complete and fulfilling, and you're not tired after. So that's kind of the gist on progesterone and sleep overall. If you are in that perimenopause, postmenopause phase, there may be a role to play in giving progesterone, either oral or topical. Oral progesterone is better seen in the research as it pertains to sleep and improving sleep quicker. I have seen topical help, but it takes a longer period of time. So when I'm looking at topical progesterone, I may be treating someone for like 3 months before I'm even expecting to see a benefit. And that's a long time if you're not sleeping. So advocating for the oral progesterone can be really game changing, specifically in that perimenopause and menopause state. If you're cycling and your progesterone is consistently low, my question is, do we need, so I see this a lot in like athletes. So female athletes who have lost their period, we're trying to get it back. And you can use progesterone as a tool to kind of pulse the system back to regulating. So a lot of the times we can give progesterone and give it in kind of a cyclic basis in order to kind of re-stimulate your system. Isn't HRT bad for us? No, there's lots of great research on hormone replacement therapy. Right now, I'm talking about progesterone, which doesn't typically come with the I don't know, the stigma that estrogen comes with. So, estrogen, a lot of people know to be like the clotting and the cardiovascular disease pieces. And a lot of people are terrified of it because of that. But I'm actually talking about progesterone. And personally, I use bioidentical progesterone, but there's a lot to be said about the oral progesterone as it pertains to sleep and helping someone fall asleep and have a better sleep. There's a lot of research in preventative care. I talk a lot about estrogen, and we can talk about this at another time, but estrogen and helping with a lot of symptoms of perimenopause in terms of like dryness, pain with intercourse, things like that can be a really, really effective tool. And the thing is when you're headed to perimenopause, into menopause, the structural changes we see in all of the genitourinary tract, which I don't think I'm allowed to say a lot of these words on TikTok. I don't know why, because it's anatomy, but the changes we see are actually irreversible. And so a lot of people don't actually realize that the sooner we intervene, the better, whether it's with estrogen and progesterone or just one or the other. But really, it's important to understand like what are all our options here as it pertains to sleep. Now, sleep goes like beyond. I just wanted to chat today about the role specifically of progesterone because I'm often looking at sleep changes being one of the first things I see in perimenopause. We know that sleep is insomnia can be actually one of the first symptoms of perimenopause when we're looking at changes. Some people don't even have changes in their period yet. Some people are just having changes in perimenopause. What tests should I ask my doctor for if I'm really hormonal and perimenopausal? The thing is, and a lot of people are surprised by this, testing your hormones in perimenopause is actually not super helpful. And one of the reasons for this is because if you're going through perimenopause, chances are your hormones are just fluctuating. Some months you'll ovulate, other months you won't. And then, you'll go a couple months and you won't ovulate, and then you will, and it'll just kind of go in that nature. And everything is pretty much unpredictable, and your estrogen is fluctuating at any given time. And so if we catch your hormones on a month where you didn't ovulate, we're going to see something different than if we catch your hormones on a month where you did ovulate. And so that isn't really helpful. And so looking at hormones specifically is never usually my goal unless someone has very consistent periods. And then I may test their progesterone 7 to 10 days after they ovulate, because then I'll be able to first confirm if they're ovulating, and then I'll be able to see how high their progesterone is getting. But oftentimes I'll do things like LH ovulation test strips so I can see, is their body creating the proper signals in order to ovulate? Like, are you actually getting, I always refer to it as like the LH hill, right? If you've ever done ovulation test strips, I do it all the time in patients who aren't trying to get pregnant. It's not just a pregnancy thing or a fertility thing, but I'm getting people to do it so that I can understand, like, are you having that hill, that luteinizing hormone hill? And then we can look at maybe testing progesterone from there. If someone hasn't had a period in 6 months, I may or may not test something like FSH, because that'll tell me if like how hard your body is working to stimulate follicles. Again, that's kind of can arguably be different the next month. Like if your FSH is high one month, maybe the next month things are lower. So unless it's like, over 100 and I'm like, oh, you're probably not going to get a period again, then I probably won't test. So that's what it looks like from a hormone perspective. But there's a lot of other things I look at in perimenopause. So I'm looking at things like vitamin D and looking at, digestion and the microbiome, and, all of those sorts of things can be super helpful in terms of giving us just an overall picture of what's going on. Insulin's a big trigger that causes a lot of symptoms and a lot of worsening symptoms. Cortisol can play a role. I think the thing is to understand when someone is looking at, oh, my hormones are a mess or I have hormonal symptoms, I think the biggest thing to consider is the fact that every single person will go through perimenopause and menopause if you have a uterus. And so Or I guess if you have ovaries, uterus, you know what I mean. But some people have an easier time than others, and the question is why, right? What other factors are contributing to it being an easier time or a harder time? And I think a lot of times when we have hormonal issues, they are really just a symptom of a bigger issue. And so, whether that issue is a digestive issue or an insulin issue or nutrient deficiencies or circadian rhythm issues, sleep for one of them, or stress, adrenal stuff as well, we have to figure out like how do we pull out which issue that is that's contributing to your hormones not, going so well. The other thing we have to understand is when we're in perimenopause, depending on how early you go through perimenopause, your risks are going to be different. So let's say perimenopause starts really early. Well, if perimenopause starts early, naturally there's a greater risk for cardiovascular disease. We have to worry about osteoporosis. We have to look at everything else. So it is important to understand like when you're in perimenopause, because there's a lot of things that we need to know. Like, what is your risk for XYZ? Do you have an increased risk for if you had like premature ovarian failure, if you had early perimenopause and early menopause, and we need to make sure that you're being treated appropriately and you've had the right testing and assessments. So confirming it is important from that perspective as well. So yeah, that's about it for today. If you want to listen to the replay, it will be in my HER Method Facebook group. If you're interested in joining that, send me a message. It's just a free Facebook group. And it will also be on YouTube. So you can follow me on YouTube and my live streams. I'm planning to be on live stream once a week, but we'll see how that goes. So anyways, guys, have a great day. If you have any questions, feel free to send them my way. Otherwise, we will talk soon.